There's a question there.
Kathy Ballard has a question.
Kathy Ray, this is a question for Ulrika. So you were talking at the end about sensor networks, and I was wondering if the kind of ideas you were talking about enabled you to design experiments with sensors, so you can work out the optimum distribution of sensors to achieve a particular goal.
I have to say this is very much at a theoretical end, and then it was I quoted a work by Geist and a student of a collaborator of him. It's a theoretical method of getting at this. So we're still at a stage where we have to sort of trying to understand what topological data analysis can do for you, and it has been applied in this area. The conference I went to went, I have to admit, more to the theoretical side rather than to the practical side. Whether experiments have been already designed, I can't say for sure. Sorry.
Any other questions? Can we please get a mic there? Lady with the grey coat, maybe.
Hi, my name is Anastasia. I'm a PhD student at UCL. I just want to make a comment rather to Emma, and I just want to say thanks to raising the treatment effect study. I'm social scientist in my background, and I actually feel quite minority here. And I actually just want to say thanks so much for talking about confounding effects. And I think that's something that's been missing a lot in data science and often ignored. And my question is, what's your perception of social science role in data science? Because I feel we get to have a voice, but it's not heard that loud. And do you think there is a future of collaborations between statistics and social science?
I certainly hope so. I mean, I think that it's kind of vitally important that there's that collaboration if we're going to answer the important social science questions. I know that there's, certainly King's and Imperial and other places have a joint doctoral training centre, which is now trying to get some of that collaboration, done more. Obviously, if you're looking at what's happening in data science and the concentration in machine learning, we were talking over at lunch, the focus being on prediction, and then it's a slightly different issue to inference. So I think we need to get those things kind of sorted out. But I mean, certainly causal inference is only something I've been working on relatively recently in my career, and I see it's important more and more as these skills and as these techniques are being used. So, I mean, certainly I'm always keen to be collaborating with social scientists and hope that there's more of that for sure.
Thank you. Can we take the question from the first line, please? Yeah.
Hi. My question is about the clinical practice. You gave a lot of examples about data science and discoveries that you have been making, but I was wondering whether these discoveries are practically used in how you conduct interviews, for example.
So I think probably one of the biggest challenges in using them is not patients, it's clinicians. So I think... and it really raises a very interesting question about how we train doctors, because I think one of the challenges we've found, even with basic monitoring, so not doing kind of very complicated stuff, is that doctors just don't really understand how to interpret the data in front of them. So I think we've got a real challenge actually in the way that we train our doctors of the future to ensure they actually can use these tools and really understand the data that they're looking at. So at the minute they get a bit of training in what a randomised controlled trial is, those sorts of things, but really very, very basic, and actually they're going to need a much better understanding of that if we're to move forward. Because most of us are using this tech all the time. It's not that it's already there. It's actually, we just need to make it so that clinical staff can actually use it appropriately. So I think there's a real, the biggest challenge is really with getting clinicians on board. I think people feel threatened that their job is somehow going to be taken away by the data that's coming from a mobile phone. I don't think anyone's proposing that at all. I think it just makes them better at their jobs, doesn't it? It means they're better informed. And if people can kind of shift their way of thinking rather than seeing it as a threat, as actually a great advantage, then I think we can begin to move forward.
So now I just have a question for you actually about that. So obviously Imperial has a medical school as well, and the training is clearly so packed. I mean, how do you find room to... It's just...
So I think the whole way we do medicine is changing because information is much more widely available. So, in fact, the idea that you go to medical school just to learn lots of facts is probably ridiculous, isn't it? Because
Actually, maybe that's true of all subjects, actually. So maybe we should be teaching people about how to do the research rather than...
How to do the research, how to interpret the facts, how to use the data appropriately and not make assumptions on the basis of it. That's what, and I very much see my role as a doctor as being someone who's assimilating it with the individual with me in a collaborative way, not being just necessarily a portal through which facts are conveyed. Because actually, you can do that with the internet. I mean, there are many ways you can do that doesn't require medical training. So I actually think we just need to be rethinking, right, about how we train people and what it is that we bring as humans that is the skill, rather than just piling on the facts.
Part of what you said, actually, I thought also brings out that maybe the patient themselves are now more in control of their data and therefore more enabled. And in particular, maybe with mental diseases, it's particularly important, and also, especially if it is non-medicated, they can really do lots of things.
But then there's a danger in the Google diagnosis, isn't there?
I wouldn't go that far, but I think that what would have been 40 years ago, which would have been me having lots of facts, that would have been my training because those facts weren't easily available. Yeah. I think it's a shift, isn't it?
Yeah, and I'm just thinking, also just knowing what you're going through and maybe what the prediction is where you're going is going to enable you to cope, which is probably half the game, in particular in this sort of disorder.
Gosh, and it's much more powerful if you've generated the data yourself, isn't it, than someone like me saying. I was giving the example to someone over the coffee break, sort of people saying, actually, you know what, I thought, well, you're probably right about this thing about alcohol and me being a bit irritable the following day. I've hated it every time you told me in clinic for the last 10 years, but now that I've actually generated this data, maybe you're right. Brilliant. I don't really care how we get to that conclusion, but it's much, much better that that's self-generated than the sort of power imbalance and things that happen when you're in a clinical interaction. So yeah, I think it's hugely empowering, providing people are given the tools to interpret it appropriately.
Sure, and not take their own medication or whatever.
Absolutely, absolutely. But I think it's an enabling a collaboration, isn't it? If both the clinician and the patients have the tools to manage the data and interpret it appropriately.
So one last question from the audience. There are still a few hands. So maybe we can take one question from a man.
Excellent idea.
Yes.
Hello, it's the token man. I was wondering, going back to the medical thing, are we going to have to educate patients as well in terms of they're now going to have what they thought was one disorder told it's actually two? Presumably, you're actually going to be moving, if I've understood what you said correctly, which is probably not, that you're not actually going to say you're an X, you've got bipolar or you've got this. You're basically just near the slight corner of this diagram, rather than you have a nice word that they can attach to. Would that be a fair characterisation?
So, it's a tricky question to answer. I think I should say before I answer it is what we know already is that our biology does not match our disorders. So if you take the genetics, they don't look anything like the categorization we've got. If you take the imaging, it doesn't look like the categorizations we've got. And then you get to sort of the behavioural measures, they don't look like the categorizations either. However, that all said, they've come from somewhere, and those are based on observations that seem to say that certain sets of things cluster together. So I don't think we're going to move to a wholly dimensional approach, but I think we may well get much more individualized in what we're doing. So you may observe that somebody's much more impulsive. We know that there's a genetic heritability to impulsivity, for example. That might change the way you manage that disorder. So I think it isn't going to move away totally from labels because we need them, because we need a way of communicating, don't we? That's clearly important. But I think if we can get to a more nuanced, individualised approach, that's much, much better. And it will certainly mean our treatments are more effective, because at the minute we assume everybody with one label is the same. And I can be absolutely clear that they're not. We're all individuals. So it's going to be finding that balance. And you're right, how we describe that is going to be really important for understanding things.